Everybody. Thank you for being here with us today. Uh, we're going to present a case that was put together by Dr. Barsukova and myself. And this case was reviewed the patient was seen by Dr. Samson, Dr. Olomu, and the surgery was done by Dr. Olomu and Dr. Chaichana. So we have a 47-year-old right-handed male patient with a past medical history of hyperlipidemia, sleep apnea, and chronic sinus obstruction. 7 months ago, he started with intense headaches and at night that he indicated that these were debilitating in nature and that he could not open his eyes because he was in severe pain. He was seen by a physician outside the Mayo Clinic. They took an MRI that really revealed a stellar mass. Then he presented to Mayo Clinic with Dr. Sampson in March of 2022 with a known pituitary adenoma and hyperprolactinemia. So the physical exam was normal. The neuro exam was completely normal. Endocrinology also indicated that everything was fine. Dr. Varsukova, do you want to talk about the labs?
Yeah, we do see what he has, like significant, like elevation of the prolactin, which more indicative, of prolactinoma rather than the stock effect based on his, high levels. He doesn't has any signs of the secondary hypothyroidism as well. No excessive, like production of insulin growth factor, which is, like doesn't suggest what he has any signs of acromegaly. But we do have, a pretty high levels in like of testosterone, and looks like patient was, placed on the testosterone pellets. Like prior, we saw the patient. That's why his, FSH and LH suppress, and also like because of aromatase, he does convert it to high level of estradiol.
Thank you.
So this these kind of labs factored in a lot into our conversation about medical management versus surgery. So one of the things that I stand behind is that when you want to initially treat a prolactinoma, you need to get control of that tumor before you treat hypogonadism, because the drive from the testosterone and the estrogen will make it really difficult for that cabergoline to do its work. And I've had patients whose tumors became very resistant or even escaped control by cabergoline because of addition of sex hormone therapy. So in his case, that was an important part of the discussion about surgery versus medical therapy in this case with the prolactinoma. And because he has pellets, we couldn't really, I couldn't just stop a therapy like an injection. These were, inserted pellets, and this testosterone was going to take a long time to drop. And so that was really the rationale between discussing those two options with him, and he chose surgery.
Yeah, in his chart, it said that the patient did not receive any medical treatment before, and that the discussion was because of the levels of the prolactin was to do surgery right away. Mm-hmm. So this is the MRI. Here you can see the sagittal view of the T1. Let me go a little bit. Let's play the coronal first. So here you can see the normal gland towards the left, and the pituitary, and the pituitary adenoma to the right side, with minimal invasion to the right cavernous sinus. You can also see that the tumor is pretty far from the optic chiasm.
Paula, isn't that the post-op scan?
No, this is a pre-op.
Okay.
And if we go to the sagittal one.
Paula, I actually think that is the post-op scan. You can see the packing in the sphenoid sinus.
Sorry, okay, so maybe I have the pre-op, sorry. I think I put both of them. Sorry, I think I put both of them The same one.
It's okay. You can just, I mean, you can just say it's a right. You can see the cavity there on the coronal. It's a right-sided paris.
That's a pre-op.
Lesion.
Yeah.
That's post there.
So basically, the tumor was on the right side. It wasn't invaded the cavernous sinus. It had minimal invasion to the right cavernous sinus. The optic chiasm was pretty far from the tumor, and you could see in the pre-op. You could see in the pre-op that the infundibulum was also there, and that normal pituitary gland was towards the left. Sorry for that. Sorry. Then we also moved to the CT scan. All patients that undergo pituitary surgery, they receive a CT scan for surgical planning. And here you can see that the inferior turbinates are highly hypertrophied, and this was taken care of by Dr. Olomo during surgery. And you can see going to the cella that the tumor was already invading the cellar floor. Dr. Olomo, I don't know if you want to comment. Right. So the diagnosis was a pituitary adenoma. The classification was a functional macroadenoma. So the plan was to observe, this was all discussed with the patient. The options were observation, medical management, as Dr. Sampson already said, with a dopamine agonist, then surgery, and then radiation. But discussion was made and surgery was decided. So the patient underwent an endoscopic endonasal transpenoidal approach for pituitary tumor resection. The patient was taken to the OR, position supine, general anesthesia was performed. The objectives of the surgery was to reverse the endocrinopathy and restore normal pituitary function, to eliminate the possibility of recurrence, and to obtain definitive diagnosis to guide management after this. So unfortunately, the ENT portion of the video was not recorded, so I couldn't include it in this video, but basically the inferior and middle turbinates were lateralized by Dr. Olumu. He obtained a mucosal flap from the middle turbinates. The ipsilateral sphenoidostia was identified and expanded to the contralateral sphenoidostia with ultrasonic bone aspiration. A posterior sectectomy was done to obtain better access. The inner sinus septation was drilled flush with the cella, and the bone overlying the cella was thin with ultrasonic aspiration. And then this is the neurosurgical portion. Once the dura was identified, here a nerve hook was placed in the epidural plane. Sorry, I don't know what's not playing. In the epidural plane to dissect the dura from the overlying bone. Then Dr. Chaichana used the carries and punches to expand the floor of the cella laterally and also superiorly towards the tuberculum. Then he used a bipolar to cauterize the dura, and then the dura was incised with endoscopic scissors in the midline. He then used a nerve hook in the subdural plane to free the pituitary ligaments. And then the lesion was dissected from the surrounding pituitary using a round knife. And then the tumor was removed, as you can see here, until the normal pituitary was seen on all edges. At the end, he moved a little bit towards the right cavernous sinus to take out the remaining of the lesion, and he identified the normal gland on the left edge. Dr. Chichana, do you want to comment something?
No, that's a good description of what I did. We extended into the cavernous sinus. We didn't open the medial wall. We thought it was clear on that side. But yeah, that's a good description.
So after the resection was done and it was confirmed that there was no tumor left, they used a biodesign to reconstruct the dura in the epidural plane, as you can see here. And then you can see how it is placed. And then Dr. Olumu placed the mucosal flap that was obtained at the beginning of the surgery. And then they placed gel foam and Surgicel bilaterally. The patient did pretty well. He awoke to his neurosurgical baseline with no CSF leaks or any type of bleeding. So this is the post-operative MRI, sorry for that. Here you can see the surgical changes and the packing, as JP already mentioned. And you can see that there was a gross total resection. And you can see the tumor on the tumor bed on the right. So the postoperative diagnosis was gross total resection of the macroadenoma, and this is a pathology report.
So as you can see here, we do have a pituitary adenoma, as we see in this conference quite frequently. One thing here that is pretty much almost diagnostic of a prolactinoma are somomatous calcifications. They get a little disrupted with the knife blade when it cuts through, but they're nice round lamellated calcifications, almost identical to what we see in meningiomas. If you go to the next slide, confirming that it is a prolactinoma is strongly positive for PIT1, which is a transcription factor found in prolactinomas, and it has beautiful staining for prolactin. So it's indeed a prolactinoma.
Thank you, Dr. Dentoft. Dr. Varsukova.
Post-op, we see how dramatically, like his prolactin, drop, and he didn't, exhibit any signs of adrenal insufficiency, as well. No, post-op concerning for the DI as well. And he was discharged without, hydrocortisone and any vasopressin.
Dr. Varsukova.
Oh, that's what I just, basically no concern for DI, and no, he was discharged with no hydrocortisone and any vasopressin. And because he has a robust, response of cortisol after surgery.
Thank you. So from the neurosurgical standpoint, his postoperative course was excellent. No complications, and he was discharged on postoperative day number 2. Dr. Sampson or Dr. Chechena, do you want to add something before we go to the pearls?
Yeah, so obviously the prolactin drop is still, there's still a lot of prolactin levels, so a lot of prolactin still there. So we'll see what Dr. Sampson can do.
Well, I'm actually very optimistic, especially given the how the surgery went. He had a long way to fall in overnight in terms of the prolactin. He was at 900 to 1,000. So you think about the half-life of the hormone. Would have loved to see it under 20 for sure. But we also see a delay in drop, and we actually are repeating his prolactin today, and we'll go from there. And so sometimes I find that the hormone is delayed because there might be a tiny bit of tissue around, but it actually degenerates. And then in the next week, you see a normalization. So I'm optimistic, and I'll keep you posted after we get the prolactin back from today.
Thank you. So as an introduction to Luisa's presentation, I just wanted to highlight some pearls for the students that are joining us today. So prolactinomas are approximately from 25 to 40% of all pituitary tumors. patients go to the doctor because they present some symptoms that are related to elevated prolactin levels, such as hypogonadism, menstrual irregularities in women, infertility, or galactorrhea. They go to the ER usually when they have any visual effect or to acute severe headache that could be related to pituitary apoplexy. Most patients, it's very important that you have in mind that most patients with hyperprolactinemia do not have prolactinomas. They could have hyperprolactinemia as a physiological effect, for example, in pregnant women, or also as a result of any medication that they could be on. Hyperprolactinemia can also result from reduced dopamine as from stalk compression from other types of lesions. So not all the pituitary lesions that you see with hyperprolactinemia are prolactinomas. Dopamine agonists are the treatment of choice, especially carvedilol or bromocriptine. There are others, but they are not widely used. And they're used with the objective of normalizing prolactin levels, restore function of the axis, stop the galactorrhea, and decrease tumor size before surgery. Carvedilol usually is better tolerated by patients and has better effects on the tumor. And then the surgery is an alternative treatment in cases of resistance or intolerance, which was not the case in this patient. Surgery was decided before. And then radiation therapy is reserved for all the resistant tumors. So this is like a treatment algorithm that I found that it explains all the things that were mentioned before and when to choose surgery and when to choose medical treatment. Thank you.
Thanks, Paola. Thanks, Sky and Dr. Susan. Nice case. And Andrea, Dr. Q was just asking, maybe you share with us the updates of the participants before we go to the next case.
Sure. We have around 50 participants from 11 countries, from 11 different countries: Mexico, Dominican Republic, Peru, Bolivia, Panama, Colombia, Italy, Spain, India, Iran, and United States.
Nice.
Thank you so much for joining.
Nice. Thanks everybody for joining us today. And I think if nobody has additional comments right now, maybe we can go to Luisa and oh, Dr. Gabriel Vargas raised his hand. Where's Dr. Vargas? Oh, here.
Yeah.
Hi.
Just hi. How are you? Now maybe I missed the reason why this patient was operated. Was decision of the patient or some because was not intolerance to the drug or to the medication, just to try to cure the patient because it was a microadenoma.
So I can speak to the discussions we had. He had an extremely high testosterone level from testosterone pellets of 1700 and an estrogen nearly approaching 100 because of those pellets. And when we do treat medically, we really want to get control of that tumor before we start sex hormone therapy. But that therapy had been started before the tumor was actually discovered. And, you know, we are talking a lot in the, at least on the endocrine side of the pituitary world, about the fact that these surgeries have really evolved so well that surgery can be offered as first line in some patients, especially NOS 1 and 2. And so that was really the patient's decision between those two options. So we could have used cabergoline and tried and seen if we could get control of that tumor. But one of the things when I lecture on prolactinomas to the fellows in Endocrine University, I show them examples of where starting sex hormone therapy has caused, especially in males, has caused a resurgence of the prolactin and the tumor as well. So you need to get control of that tumor first. And given that the pellets stay around for 4 to 5 months, we weren't really sure if we would be successful with that. But it was definitely an option. And the patient chose this approach.
It is nice. It is nice because many times the endocrinologists don't like that we offer surgery for this kind of tumor. They always say, don't offer surgery, please try medication first.
Right. So I just finished working on a paper with one of my former fellows in a previous institution where we have 60 patients who went to surgery, and the remission rates are extremely high, even in macroadenomas. NOS1 and 2 with intention to cure is almost 80% versus a patient being on cabergoline for many, many years. So it is an opportunity. The motivation for many of those patients, as you point out, was intolerance or the inability, a lack of desire to be on medication for a long time. So it certainly is an option with the evolution of transpenoidal resection.
I don't know, JP, if you remember the name of a Japanese surgeon that always do surgery for prolactinomas. Always. More than, I don't remember the number, 1,000 cases of prolactinomas doing surgery in control of the prolactin in more than 90% of this guy. I don't remember the name, but I remember the conference of a surgeon. And I remember also when I was resident many years ago, more than 30 years ago, we offer many times surgery because of the cost of the medication was so high. So it's good to hear that position. Thank you.
And I think that just, I don't know what the discussion was, but I can say that as I travel around the world and we do a lot of surgery in many places, it's still surgery is the first line of therapy for prolactinomas in developing countries, not medication, for this precise reason that Gabriel just mentioned. So the better surgeons we become, the better we learn how to do this, the better we're going to help a lot of people around the world. It's much less expensive to do what Gabriel just mentioned, the surgery, than to treat patients with medication. I mean, they just cannot afford it. You know, in other parts of the world, either they eat, or actually they just flat out, they just cannot afford it, period.
Yes, just for the trainees, you know, cabergoline has been around since the 90s, bromocriptine since the 70s, but a cabergoline prescription can run you $400 to $1,000 a month, depending on how much you're taking. So it's not a very cheap medication.
I know, and remember, there are places in the world where people make $2 a day to feed their families. You know, you go to India, you go to Mexico, in some parts, it's impossible, it's costly prohibitive. So a lot of our colleagues, you know, and Gabriela, as he mentioned, they go on and they have to see these patients with these diseases, and they got to give them the best therapy. This is why I think that the way that we have evolved in the surgery, you saw the beautiful surgery that Kai just showed right now. I mean, the better we evolve in this, the better we're going to be able to help people. So do we have a second case, or where do we stand, Susan?
We do,
We do.
and it is consistent with the theme.
Excellent.
Dr. Vargas will be pleased.